Hello, and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm your host, Gillian Whiting, coming to you from Meanjin, the land on which this podcast is being recorded.
And I'm Dr. Maria Bolton, GP specialist and former president of the Australian Medical Association of Queensland.
Today, we're talking about endometriosis, particularly around the role Botox can play in relieving pain.
To discuss this, we're joined by Mater Private Hospital, Brisbane, gynaecologist Dr. Albert Jung.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Albert, welcome to sMater.
Thank you very much. Very happy to be here and very excited.
It's good to hear. Now, the prevalence of endometriosis we know has increased in recent years from 1 in 9 women to 1 in 7. What's the reason behind this increase?
Well, I think there's lots of reasons for this increase. I think number one, the education around patients and for GPs has increased dramatically, which is really great. I think we have a much lower tolerance to accept pain as normal part of monthly periods. I think that's the biggest thing that's changed over the last few years. Certainly our access to really good quality ultrasound scans, MRIs, and also to laparoscopies is at a level that we've never had before. So those are really important things. There is some really interesting research that suggests that perhaps our increasing increasing age of first-time mums has an association with increasing rates of endometriosis, and also our reducing birth rates might have an association with increasing rates of endometriosis. Those aren't quite causation yet, and there might be some more to uncover there, but there's lots of different reasons as to why that seems to be increasing.
Albert, I've been a GP for more than 20 years, but lately, over the last few years, I've seen a lot of women present in their 40s and even their mid-40s with endometriosis symptoms. Is that something that you're seeing as well?
I'm definitely seeing some of that. And I think it's perhaps, again, that tolerance of, hey, I've lived with this for 20 years, but maybe this isn't normal. It's sometimes their daughters that are first getting diagnosed and going, there's a familial aspect to this, and maybe a lot of the symptoms that I've been feeling as well are endometriosis related. Yeah.
What are the conventional treatment options for endometriosis, and do they vary according to what stage in life you're in?
Absolutely. So the two main conventional treatments are really surgery, and specifically I'm talking about excisional surgery. There is some role of ablative therapies, but we're really talking for superficial endometriosis, not for your deeply infiltrating endometriosis. And the other is hormonal suppression. Hormonal suppression in the form of the pill, the Mirena, the Depo, the Implanon, really anything. Unfortunately, those hormonal suppressants will prevent you from falling pregnant. So we really need to take that into account as to where the patient or the woman is in their journey of fertility or having children. And that's probably the biggest thing that needs to be taken into account. Once they are done having children, absolutely, as part of the surgical management, a hysterectomy should be part of that conversation. To be clear, a hysterectomy is never going to solve your endometriosis, but it is absolutely appropriate for that to be part of that treatment process.
For those treatments of women of childbearing age, how effective are they?
On the whole, they're quite effective. And again, those two, surgical excision and hormonal therapies, have good proven evidence for not only symptom control, but reducing progression of disease into the long term. Of course, there's lots of other things that will help from a symptom control point of view, but it is really important for us to really look at fundamentally have those two as foundational pieces as to management of endometriosis.
How does Botox work to relieve pain in patients with endometriosis?
Yeah, so Botox is something that we use a lot of, particularly for women who have refractory pain secondary to endometriosis. So to be clear, what we're really focusing on is the pelvic floor muscles that are too tight. They're overactive or hypertonic. So to take a step back a little bit, our natural response to pain is to contract our muscles. So if you have pelvic pain secondary to something like endometriosis, our natural response for our pelvic floor muscles is to contract. Unfortunately, sustained contraction in itself then leads to pain. Yeah, think about holding onto a grocery bag for a long period of time. And also sustained pelvic floor contraction then leads to bowel dysfunction and urinary dysfunction as well. So what we're really aiming to do here is to relax those pelvic floor muscles that are overactive in the aim to relax them to help normalize some of those symptoms again.
What does the research say on this, the trials and studies that have been done to support this?
Yeah. So the research around the use of pelvic floor Botox for hypertonic pelvic floor muscles has been around for 20 plus years. So Professor Jason Abbott, based in Sydney, published one of the first pilot studies on this in 2004. And the research, again, when used in conjunction with pelvic floor physiotherapy, is really, really positive.
So they need to be, it's not a magic cure, they need to be used together.
Correct.
Yeah.
So Botox will do a great job of paralyzing the muscle, but to sustain that retraining, it really needs to be in conjunction with a pelvic floor physiotherapist. And that's where we find the most benefit. So patients who have had pelvic floor physiotherapy, but have had some refractory sort of ongoing tightness, those are the patients that seem to benefit most from pelvic floor Botox.
Does Botox play a role in also reducing the bowel symptoms? Has that been shown in trials?
So yes, again, when you have an overactive pelvic floor muscle and you can't relax those pelvic floor muscles when you want to open your bowels, it absolutely can lead to constipation and other bowel symptoms. So yes, Botox has been shown to reduce those symptoms, but also Botox, our colorectal colleagues will often use Botox in their anal sphincter muscles for, again, very similar overactive anal sphincter tone.
Are there any potential side effects with using Botox in treatment of endometriosis?
Unfortunately, as with everything, there are some side effects. The first side effect that I always mention to the patients is, again, as mentioned, Botox is very good at leading to paralysis, but it's not as effective at leading to pain reduction for everybody. So I do say that it's effective about 75% of the time in reducing pain. Because it is an injection, there can be some tenderness around the injection points when we administer the medication. And lastly, very uncommonly, we can have some bowel or bladder dysfunction, namely in the form of incontinence or retention.
Is there any patients that you would not use the Botox on? Any contraindications or conditions that would make Botox completely an unsuitable treatment option?
So if you had any sort of allergy to Botox, that would preclude you from having Botox treatment. We would need to ensure that you're not pregnant at time of Botox injections. Some extra care needs to be taken into account if you are hypermobile. So if you've ever been diagnosed with something like Ehlers-Danlos syndrome, and your absolute contraindications are going to be things like your myasthenia gravis or your motor neuron disease. So anything neuromuscular disease, a formal diagnosis of that would be a contraindication there.
What is the recommended dosage and frequency of the Botox injections?
So I use something called Dysport, which is a different trade name. And in that formulation, we'll use 300 international units with about 100 going into the left obturator internus muscle, another 100 going into the right obturator internus muscle, and the rest 100 going into the pubococcygeus muscle, which makes up the levator ani complex there.
What about monitoring them after that?
Yeah. So monitoring them after that in the immediate post-operative phase, as long as patients can urinate and mobilize, they're safe to go home. Again, importance of good pelvic floor physio follow-up there is absolutely paramount. We can then repeat these doses as needed, ideally 6 to 12 months apart.
What are the long-term outcomes of patients using Botox injections as treatment for their endometriosis pain?
Again, long-term outcomes are really quite favorable. It does require a certain amount of motivation on the part of the patient with ongoing pelvic floor physio follow-up. And it's pretty uncommon for us to have patients who need more than, let's say, 3 doses of pelvic floor Botox.
You mentioned, Albert, that this has been used for some time and treating pain for endometriosis patients. How has the Botox treatment changed in recent years?
The Botox treatment, certainly the rates of treatment or uptake of Botox has increased quite significantly. And I think part of that is, again, this is a treatment that's been around for 20 plus years, but it's a better understanding of endometriosis and pain. Aside from a very simple, hey, there is endometriosis and it sends signals and there's pain, but a much more multidisciplinary sort of approach to management of endometriosis with our pelvic floor physios, with our pain specialists, with our pain psychologists. And so with that has absolutely increased.
Is cost a factor with patients accessing Botox treatment?
Unfortunately, cost can be a factor. Botox, for this purpose at the moment, is not on the PBS, so it will set patients back on average about $400 to $500 for the Botox itself. Yes.
What about medicinal cannabis? Is there any evidence that is useful in treatment for the pain of endometriosis?
Medicinal cannabis is a really interesting area of research right now, and there's lots of research that is going into this. At the moment, when we specifically look at medicinal cannabis for the purposes of endometriosis, there's actually not a lot of great evidence. So when we pool that data looking at pain and medicinal cannabis, those populations often included cancer patients and trauma patients and endometriosis patients altogether. But again, when you separate those patients, the evidence isn't that great. Having said that, when we look at some of the evidence that has come out from places like Canada, where they've completely decriminalized medical cannabis, and medical cannabis is incredibly easy to find, and you then survey women who have endometriosis and ask them, do you use medical cannabis? And a good percentage, about a third of women, will say they do. So to be clear, this isn't not to be mistaken for a randomized control trial, but also women wouldn't necessarily use medicinal cannabis if they didn't find it to be helpful. So I think this is absolutely an area where we need to keep researching and keep an eye out for. Absolutely.
Is there any research into the links between endometriosis and any other autoimmune disorders?
There are absolutely links between other autoimmune disorders and endometriosis, and that's another big area of research for endometriosis. We don't really truly understand the cause of endometriosis. We appreciate that there are several different genes that have been identified as associated with endometriosis. We now know that there is certainly a familial link. So if you have a first-degree relative, i.e. a mother or sister, your endometriosis risk goes up significantly. I've recently audited some of my data, which we'll present at the upcoming World Endometriosis Society conference. And any symptom with the family history confers about a 90% risk of endometriosis there. So I think family history and genetics is also quite undervalued at the moment.
What do you see to be the future in endometriosis management?
I think for endometriosis management, we're heading in that direction, but non-invasive diagnosis of endometriosis is a big space that we've made lots of gains on over the last 5 to 10 years. I would love to see some more non-hormonal management options that are available for women. And again, a greater appreciation of a multidisciplinary team approach to management of this chronic disease condition.
Well, Albert, thank you for dropping in to sMater after surgery today. We thank you so much for sharing your expertise with us. But before you go, we have a little segment we want to introduce you to. It's called The Checkup. So Maria's got 5 quick questions. It's designed to show us a little bit more about you at the professional as well as the personal. So are you ready to go?
Ready as I'll ever be. Let's do it.
Albert, if a genie could grant you one wish, what would that be?
I would say sleep. I have 3 very young children, so sleep. That's an easy one.
What's your secret superpower?
Ooh, my secret superpower might have to be, maybe not a superpower, but a talent. I make a pretty mean mac and cheese.
If you could impart one piece of knowledge on a medical student, what would it be?
I would say do what you love. Find what you love. Find the specialty that you're happy to get up for every morning, and everything else will sort itself out.
What's your superstition?
My superstition. I have a few. This might be a bit technical. We have a little device where we clean the laparoscopic scopes. But we also have a little port cleaner that we do, and those 2 things have to be used in conjunction at all times. You can't do just the cleaning of the lens without the port cleaning.
And who's the most underrated member of the hospital team?
Underrated member of the hospital team? Ooh, gosh. I would have to say food services. They keep absolutely the patients well fed and they keep us well fed. So I'm going to say food services for me.
Albert, thank you so much for joining us. Good luck with the sleep.
Thank you so much. This has been a real pleasure.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
See you next time on sMater.